they suppress those ectopic foci. And Vaughan Williams was the one that came up with this classification of medications. And this is my least favorite class of medications. It's the most difficult one to memorize when you're in pharmacy school. I do not like this class of medicine, but they help a lot of people. And I'm forever grateful that someone did come up and came up with this class of medications so that we all can learn it and struggle through it together. But it's a very difficult class of medications to learn. So the first thing we're going to talk about is the 5 phases of cardiac cell activity. So phase 4 is whenever your heart cells are at rest. And then phase 0, we have a rapid influx of your sodium ions. And then in phase 1, your sodium is going to decrease and your potassium is going to exit the cell. And then you have phase 2 where your calcium moves in, but potassium is still exiting. And then phase 3 is when your calcium movement is going to stop, but your potassium outflow continues. So potassium exits basically during 3 phases of this, and sodium only affects that phase 0. And this is a diagram that depicts this and the different phases of the cardiac cells. So class 1. Class 1 is actually broken down into 3 subgroups as well. You have your class 1A, and your class 1B, and your class 1C. And how I remember these in school is double quarter pounder, mayo lettuce, and fries please. So your 1A is going to be your disopyramide, your clonidine, and your propanamide. And then your class 1B is your mayo and lettuce. So with that, we have your mexiletine and your lidocaine. And then your class 1C is going to be your fries please, which is going to include your flecainide and your propafenone. So it's an easy way to remember it, but this is a big class. So with this class, they slow the movement of the sodium in the cardiac cells. Propanamide, which is your class 1C, suppresses the activity of those ectopic foci, and they slow that conduction velocity. And then lidocaine blocks those sodium channels. Lidocaine is used to resolve ventricular dysrhythmias and suppress those ectopic foci. Your class 2 are going to be your beta-adrenergic blocking agents. These are going to inhibit that catecholamine activation of the beta receptor sites, which we kind of already talked about. They can be capable of beta-1 selectivity at therapeutic doses. So you have beta-1 and you have beta-1 selective beta blockers, and then you have non-selective beta blockers. So non-selective beta blockers that I can think of are carvedilol, propranolol, and labetalol. Most of the others are selective. And how you remember the selective ones, there's an acronym, I think it's called MANDATE, that I used in school to remember those. And then with this class, they can cause massive conduction abnormalities when given with calcium channel blockers. So when you're a pharmacist, it's a major drug interaction, so you have to call the doctor usually on that. Let's see here. So metoprolol, like I talked about, reduces the heart rate and decreases the myocardial ischemia and atrial tachycardia in patients. But it is a selective beta blocker. Class 3, we've got prolongs the absolute refractory period, and then it treats the atrial or ventricular tachycardias. Amiodarone, that's a class 3 one, and it is controversial in the treatment of Wolff-Parkinson-White, which I don't know if you guys are familiar with that, but it's basically where there's an extra electrical pathway that causes tachycardia, if I'm remembering right. But this drug is also used to treat lots of other things, and has very serious side effects. So when patients are on this, the patients usually have to be monitored very closely. They have to have regular eye exams because this drug can cause optic neuropathy. It also can cause pulmonary fibrosis, so those patients need to have regular pulmonary function tests. It can cause like a blue-gray man syndrome, I believe, where people will have like almost a grayish or blue scheme to their skin as well. So it's a weird drug, but it helps lots of patients, but the patients need to be monitored very closely. And then we've got Sotalol, which is taken orally for the ventricular or atrial dysrhythmias. And then we've got class 4, which is the calcium channel blockers. but not all calcium channel blockers, because we have our non-dihydropyridine calcium channel blockers, which are the ones it's talking about, your verapamil and your diltiazem, which reduce blood pressure, control heart rate, and they treat cardiomyopathy. These medicines are going to displace the calcium at the receptor sites or enter smooth muscle cells in the place of calcium. They also decrease the automaticity of ectopic foci and the velocity of cardiac contraction. And here we've got verapamil and diltiazem listed. These medicines are typically used in patients with atrial fibrillation or atrial flutter. Typically given IV over 2 minutes and require continuous electrocardiographic monitoring and frequent blood pressure monitoring. And just for a little kick and grin, the dihydropyridine calcium channel blockers are going to be things like amlodipine, nifedipine, and nicardipine. The next one we've got listed for cardiovascular medicines is adenosine, and it's not really in a class, it's in its own class, but it decreases cardiac conduction velocity and prolongs that refractory period. It's used to evaluate the ECG tracing, has rapid onset but a short duration of action, and is usually given through a large bore IV. Then we have our alpha receptor antagonists, which prevent the endogenous catecholamines from reaching those alpha receptors. So they're going to decrease blood pressure and decrease that systemic vascular resistance. These are beneficial in patients with hypertension, enlarged prostate, or glaucoma. So here I think about doxazosin, prazosin, tamsulosin, which is typically used for prostate, because like I said earlier, it's just effective on the alpha-1A receptor. And then this slide is just that continued. Clonidine is tricky because clonidine is an alpha-2 receptor agonist, but it works through feedback inhibition. So it actually does decrease blood pressure even though it's an agonist. And it's emergency treatment with hypertension and typically works really well. And then you've got phentolamine, which is subcutaneously injected to reverse vasoconstriction. And then labetalol, which I talked about earlier, is a non-selective beta blocker and has alpha-1, beta-1, and beta-2 properties, and usually is a preferred drug in hypertension and pregnancy. And that and methyl-dopa are. Let's see. Angiotensin converting enzyme inhibitors. So these alter the function of the renin-angiotensin system. They cause blood pressure and cardiac afterload to decrease. That's their main mechanism of action. They're used to treat hypertension, have mortality benefit in congestive heart failure, and help with cardiomyopathy. The medications that fit into this class are going to be your lisinopril, your benazepril, enalapril. Those are some ones off the top of my head. And then with this medicine, you have the adverse side effects such as a chronic dry cough and angioedema. Angioedema is where your tongue and your mouth, your face swells, and typically that's more common in your African American population, but it can happen even after you've been on the drug for a long period of time, so it's a big counseling point with that medication class. And then we have our anticholinergic medications, and a big one that affects the cardiovascular system is atropine, because it's a muscarinic receptor antagonist, and its effectiveness is related to its concentration at the receptor sites compared with the acetylcholine we talked about earlier. It's going to treat bradycardia when vagal stimulation of the muscarinic 2 receptors is suspected. It's used before airway manipulation, and another thing, important thing about this drug is it's used for acetylcholinesterase toxicity. Now we're moving into another class, the catecholamines and sympathomimetics. The catecholamines stimulate the receptor sites in that sympathetic nervous system. They contain a catechol group and a monoamine oxidase group. They are rapidly metabolized and typically have a short duration of action. Your sympathomimetics are synthetic chemicals that mimic the catecholamines. That's your fight or flight system. These include drugs like your amphetamines, your albuterol, phenylephrine, cocaine, that typically have a longer duration of action than the chemicals that are endogenous in your body. Epinephrine or adrenaline, a catecholamine that stimulates that alpha-1, beta-1, and beta-2 receptor sites. They can be given IV, IO, IM, multiple different routes. Can increase the cardiac workload and increase the oxygen demand because they're affecting alpha and beta receptors and stimulating those. Norepinephrine or Levophed stimulates beta-1 and alpha receptors, is usually given continuous IV. It's really bad about causing extravasation typically, and is usually given in your critically ill patients. Phenylephrine is almost a pure alpha agonist. It's a very potent vasoconstrictor. Once again, we have extravasation as a concern when giving it, and can cause reflex tachycardia. That's a common side effect of this medicine, and then tachyphylaxis. Now we're moving into the direct vasodilator medicines, which are used for uncontrolled hypertension, congestive heart failure, MIs, cardiac ischemia, and cardiogenic shock. Nitroglycerin is a big one, and you guys probably use this relatively. You guys probably use this pretty frequently. It dilates your veins and coronary arteries. It's used for relief of chest pain and decrease in blood pressure. And here's kind of what the IV dose should be. People can become tolerant to it. If the patient keeps these at home, they need to make sure they replace them on a regular basis. They do degrade and disintegrate, and they should not be kept for longer than 6 months, even though a lot of times patients will keep them longer than that, and then come in and wonder why their tablets are like disintegrating in their bottle. So it's really important. It can affect the effectiveness of the medication too, so it's a big counseling point. And then another big counseling point is this medicine should never be given with phosphodiesterase 5 inhibitors, which are going to be your Cialis and Viagra, because it can cause a major drug interaction. So big major drug interaction and a major counseling point for nitrostat. And then sodium nitroprusside is a potent IV vasodilator, also affecting the smooth muscle of veins and arteries. It has adjustable IV infusion rates. I'm not super familiar with this one, so I'm just going to touch on that one. And then diuretic medications. So here we're going to administer these to correct volume overload, manage your heart failure patients, improve respiration in your pulmonary edema patients because we're decreasing the fluid, and then it helps preserve your kidney function. Furosemide. We talked about Lasix earlier, our furosemide used for diuretic, and can manage all the things I just talked about. You have to have careful consideration before administering it to patients because you have to monitor their hemodynamic instability and their electrolytes on a regular basis because it does affect the sodium and potassium levels. Here we have Mannitol, which is an osmotic diuretic, and it's used to decrease intracranial pressure associated with cerebral edema. And then on the right side, we've got the different types of diuretics and what medications fall into the different classes. So you have your loop diuretics, your Lasix, Bumex, Demodex, potassium-sparing diuretics, spironolactone, thiazide diuretics, and then it lists some vasodilators and combination drugs. And a lot of times combination drugs like lisinopril and hydrochlorothiazide are given together to help balance out that patient's potassium level. Antihypertensive agents, obviously used to treat high blood pressure in patients. Diuretics and beta blockers can be used in many other classes of medications. Patients taking antihypertensives can experience hypotension and also orthostatic hypotension. So when they first start taking a blood pressure medicine, they need to be making changes slower. So going from sitting to standing slower, and also getting out of bed first thing in the morning slower than normal. Here's some commonly prescribed antihypertensive agents. So once again, we've got our non-selective beta blockers, labetalol, which is used, it's pretty commonly, but it is used most commonly for hypertension and pregnancy. And then you've got your propranolol, which is non-selective for hypertension. And then also carvedilol should be included there. And then you've got your angiotensin-converting enzyme inhibitors, which we talked about with lisinopril, enalapril, benazepril. And then angiotensin receptor blockers have similar mechanism of action as the ACE inhibitors, and so that's going to include your things like losartan, valsartan, irbesartan, and then your alpha agonists, which work through feedback inhibition, clonidine, and then methyl-dopa, and then your alpha blocker, prazosin, doxazosin, and then it's got other antihypertensive there, reserpine, and then we have our cholesterol-lowering drugs, our statins, niacins, bile acid resins, and fibrates, and then our vasodilators. So blood products and medications affecting the blood. So now we're going to transition into blood products. Blood product administration, the average adult has about 5 liters of blood, and blood constitutes approximately 7 to 8% of the body weight. Trauma or a medical condition can alter the total amount, composition, and performance of the blood in that patient. Blood components are type-specific, cross-matched, and unmatched, and if you're unsure, you need to contact an expert. Tranexamic acid promotes blood clotting and reduces mortality in trauma patients with severe bleeding. It can also be used to prevent bleeding in menorrhagia orally. Anticoagulant medications. So these are going to impair the function of clotting or the coagulation chemicals in the bloodstream, and it's going to enhance the function of substances in the blood that inhibit that clot formation. It's going to prevent formation of clots and the growth of existing clots. And here we have a couple anticoagulants listed, heparin and enoxaparin, which can be used in treatment of DVT or prophylaxis to keep a DVT or deep vein thrombosis from happening. Fondopurinox is a heparin-like product also used to prevent or treat DVTs. Warfarin. So the anticoagulants work on the coagulation cascade. So with warfarin, it inhibits factors 2, 7, 9, and 10 in that coagulation cascade, as well as protein CNS. It's very common. Patients are at risk for bleeding if their INR is not monitored adequately. Some other ones that aren't listed on here are going to be your factor 10A inhibitors, your Xarelto, and your Eliquis, which inhibit factor 10A. And then you have your factor 2A inhibitors, your direct thrombin inhibitors like Pradaxa. Antiplatelet medications prevent new thrombus formation or extension of an existing thrombus. These are going to include your aspirin, your clopidogrel, ticlopidine, glycoprotein 2A inhibitor medicines. A couple other medicines are going to be Brilinta or Ticagrelor and Effient that aren't listed on here. Fibrinolytics or clotbuster drugs dissolve blood clots in your arteries and veins, can cause life-threatening hemorrhages. Prolonged pre-hospital time can preclude administration. That's a really big thing. Opioid medications used as analgesics in the pre-hospital setting. They stimulate those opioid receptors. You have 2 different types of opioid receptors, your mu receptors and your kappa receptors. Most just stimulate mu, but tramadol stimulates mu and kappa receptors. They can be known to cause tolerance and cross-tolerance. They can be addictive. And then these are some side effects: sedation, respiratory depression, and apnea. Morphine is a common opioid medicine. Can cause severe nausea and vomiting, can produce a histamine-related reaction in patients. If the patient experiences that, then you can give them something more synthetic like fentanyl, which we talked about earlier, and it'll be less likely to cause that same reaction in that patient. It doesn't have the same risk of nausea and vomiting and histamine release as the morphine because it's more of a synthetic chemical. Then we have our opioid antagonist medicine, naloxone. It reverses the effects of excessive opioid chemicals in the body, and the efficacy is dose dependent. Typically only want to give this in life-threatening situations. This slide, phenytoin and fosphenytoin are not opioid antagonist medications. They're a seizure medicine, and they can be received on a long-term basis or a short-term basis, and can be given by IV infusion. This drug typically has a narrow therapeutic index, and the levels need to be monitored because it can cause serious adverse side effects. But there's less side effects with the fosphenytoin than the phenytoin. Now we're going to talk about drugs that affect the GI system. Antiemetic medicines used to prevent nausea and vomiting. Here we have your promethazine and prochlorperazine, can be given orally or IV. Medicines that are used in a pre-hospital setting, these are kind of miscellaneous. So we've got Tylenol here, which is an antipyretic, so it helps with fever. It also has analgesic properties, so it helps with pain. It's available in various dosage forms. Not listed here, Tylenol is available IV and is given quite a bit in the hospital IV as far as I know. Oral administration should be avoided in patients with high risk of seizures or airway compromise. It doesn't really have that many adverse side effects either. Calcium preparations can be used as or for an antidote to calcium channel blockers. You can treat magnesium toxicity with it. Calcium repletion in patients with low calcium, calcium restoration from hydrochloric acid, and you can prevent hypotension with it. Calcium comes IV two ways, calcium chloride and calcium gluconate. It's common to cause extravasation, so you have to be careful when giving it IV, but it should never be given sub-Q or IM. Dextrose, it's used for hypoglycemia or low blood sugar in patients and should be administered through a large IV catheter, and then here listed is your initial dose. Diphenhydramine or Benadryl is used for a variety of situations, but most commonly allergic reactions. Here it says it has mild sedative and mild antitussive properties. It also can be a good antiemetic in certain situations. It's a competitive histamine 1 receptor antagonist. It's actually a first-generation antihistamine, so it does have more sedative properties than some of the other second-generation antihistamines like your Allegra and Zyrtec. And then adverse effects, we have sedation, palpitations, and anxiety. Glucagon, naturally occurring peptide, that was manufactured commercially, used to treat low blood sugar, can provide increased heart rate and contractility, which is why it is used in calcium channel blocker overdoses and beta blocker overdoses. It also can treat a patient who has a foreign body lodged in the esophagus. Magnesium sulfate is another electrolyte, can be used to treat ventricular dysrhythmias, correction of low magnesia, prevention or treatment of seizures in pregnant patients with preeclampsia or eclampsia, and replaces magnesium deficiencies in the body. It helps dilate the smooth muscle tissues. And then sodium bicarbonate, it's an alkalizing agent, so it makes everything more basic. It can be administered by rapid IV push or added to IV fluids for intermittent or continuous infusion. And then excessive administration can cause alkalosis, fluid overload, electrolyte abnormalities, and then you've got cerebral and pulmonary edema. And then that's the end. So if you guys have questions, please let me know. It's a lot of material and lots of information, so sorry I went through it so quickly.
Thank you.
Mm-hmm.